So we proceed to the second part of our talk, bleeding in early pregnancy, part 2. And here we are going to talk about ectopic pregnancy and hydatidiform mole, or trophoblastic disease correctly. So ectopic pregnancy, by definition, is implantation of the conceptus outside the uterine cavity with a frequency rate of 1 to 2 per 100 pregnancy. And as you can see in this picture, it could be implanted outside the uterus, mainly the fallopian tubes, or 90 to 95% of it. It could be within the muscles, which is usually rare. It could be ovarian, as we'll see in a minute. It could be abdominal, and it could be cervical. So implantation outside the uterine cavity. This is the normal procedure whereby the ovum released here, captured by the fimbrial end of fallopian tube, travel through the fallopian tube, become fertilized within the fallopian tube, moves, and then eventually be implanted in the uterine cavity. This is a normal thing. The fertilized ovum here, fertilization takes place in the tubes. The fertilized ovum reaches the uterus and becomes implanted here. That is the normal pregnancy. In ectopic pregnancy, the egg implantation could be in the fallopian tubes or in other places, as we have said. So it doesn't reach the uterus. The egg traveling down the fallopian tube, the eggs being fertilized, and then it's implanted somewhere in the fallopian tube. This is the commonest site. Okay. Common sites for ectopic pregnancy, as we have just mentioned, the fallopian tubes, almost 90 to 95% of it. And it could be in the isthmus of the fallopian tube, it could be in the ampulla of the fallopian tube, and rarely at the fimbrial end. So the commonest is the fallopian tube. The uterine cornea is about 2 to 2.5 or to 3%, figure being given here at 3%. Then the ovarian, it could be in the ovary. It could be cervical in the cervix. It could be abdominal, just outside. Sometimes, rarely in the cesarean section scar, previous cesarean section could be there. So these are the common sites of an ectopic pregnancy. Usually it is on the right side. The risk factor for ectopic pregnancy could be within the tube itself, tubal factors. As we have mentioned, almost 90 to 95% of it occurs in the tube. Tubal risk factors are pelvic inflammatory disease, use of intrauterine contraceptive devices, assisted reproductive technology, tubal damage, surgical occlusion or serial damage, either infection or surgical occlusion, tubal surgery. This is historical. In the past, we used to do for infertility due to tubal blockage, we do tubal surgery. We open the tubes or we do salpingolysis. We take the adherents around the tube. That was used to be the management in the past. Nowadays, blocked tubes, we go for assisted reproductive technology more than tubal surgery. Tubal surgery has been noted to be accompanied with risk of ectopic pregnancy. Then salpingitis, isthmica nodosa. All these are within the tubes factors. Other factors, prior ectopic pregnancy. If she had one before, she is likely to have a recurrence or another ectopic pregnancy. The age, The risk is threefold greater in women of 35 to 40 years of age compared to younger ones. The older, the more likely she may have an ectopic pregnancy. Non-white race, endometriosis, she had multiple sexual partners, overdevelopment of an ovum with external migration from one side to the other, being caught in the midway, fertilized by the sperm, and causing an ectopic pregnancy, and smoking. So factors on the tube, and these are the general factors. Clinical presentation, often asymptomatic. Usually there is an amenorrhea of 6 to 8 weeks, the history they give you, with minimal vaginal bleeding and could be brown in color rather than frank red in color. Amenorrhea, minimal vaginal bleeding, lower abdominal pain, often mild, vague, and classically unilaterally on one side. Diarrhea and vomiting, dizziness and lightheadedness, shoulder tip pain, that in case where the tubal pregnancy has ruptured, leading to hemoperitoneum, blood in the peritoneal cavity, irritating the diaphragm, causing the shoulder tip pain. And the worst part of it is the collapse. Severe bleeding, leading to internal hemorrhage, leading to collapse. So from often asymptomatic to the stage of collapse. These are the clinical picture. On examination, often no specific signs. The uterus usually normal in size. What we used to see sometimes is cervical excitation and adnexal tenderness. That's to say, when one performs vaginal examination, he or she moves the cervix from one side to the other, the patient usually feel severe pain and she may jump. And that's what we call cervical excitation. We may be able to feel an adnexal mass. That's to say, the ectopic is outside the uterus in one of the adnexae, but it's rarely felt. Peritonism is possible. Investigations you need to do for an ectopic pregnancy, beta HCG. We usually say a beta HCG of 1500 internationals per liter is usually accompanied by an intrauterine pregnancy. So we repeat the serum beta HCG in 48 hours, and we see the rate of the rise. Intrauterine pregnancy, it should be rising, the beta HCG. And the rise should be over 66% in cases of intrauterine pregnancy. In other words, if it's an ectopic, there may be a rise, but it won't reach 66%. And that suboptimal rise is suspicious, but is not diagnostic. So rising beta HCG, probably it's an intrauterine pregnancy. Not rising, suspicion is there, and you need to go further for confirmation of the diagnosis. Serum progesterone usually distinguishes whether the pregnancy is failing, showing that a progesterone level greater than 25 nanogram per ml is associated with an intrauterine pregnancy in almost 97.5%. That's to say, we do it to be sure that the pregnancy is progressing. Another investigation, transvaginal sonography. That is very good because here It establishes the location of the pregnancy. Is it intrauterine or outside? It also establishes the presence of an adnexal mass, if it is there, and fluid within the pelvic cavity or abdominally. Absence of gestational sac on ultrasound with a beta HCG of 2,500 is very likely that this is an ectopic. Diagnostic, still investigations. As we have said, beta HCG, serum progesterone, transvaginal sonography, laparoscopy. Laparoscopy could be both for diagnosis and treatment, as you will see. Coldocentesis, when quickly through it, is that getting some blood, you put a needle in the posterior fornix and you aspirate. If you aspirate blood, we used to believe that this is a ruptured ectopic pregnancy, but that's not a reliable and sensitive test because you may be aspirating from a vessels and the risks are severe, so we no longer use it. It's just to know that historically it was used to be used. Differential diagnosis of an ectopic could be obstetric problems, gynecological problems, or non-obstetric and gynecological. Obstetric diseases, miscarriage, as differential diagnosis in case of ectopic pregnancy, of an early intrauterine pregnancy. Miscarriage followed by salpingitis. miscarriage الإيرلي اللي هو threatened miscarriage. حصل miscarriage followed by salpingitis. Early pregnancy with pelvic pathology in the corpus luteal cyst. Retroverted gravid uterus. And septic abortion. This is obstetric differential diagnosis of an ectopic pregnancy. Gynecological, degenerating fibroid, dysfunctional uterine bleeding. Nowadays we call it abnormal uterine bleeding or heavy menstrual bleeding. The term of dysfunctional uterine bleeding has been changed into abnormal uterine bleeding or heavy uterine bleeding. Endometriosis, ovulation pain, ruptured corpus luteum, torsion of adnexal mass, acute or subacute salpingitis. All these are gynecological diseases. They could be mixed for ectopic pregnancy, and they should be differentiated from ectopic pregnancy, each with its symptoms and signs. And dysmenorrhea. Non-gynecological conditions, appendicitis, gastroenteritis, mesenteric thrombosis, perforated peptic ulcers, renal colic. So ectopic pregnancy need to be differentiated from obstetric problems. We have mentioned gynecological problems. We have mentioned, and these are the non-gynecological conditions which could simulate the presentation of an ectopic pregnancy and need to go for a proper differential diagnosis. Intraperitoneal hemorrhage from any source, rupture of the spleen and splenic aneurysm or tumor. Treatment, the same as for miscarriage, expectant, medical, surgical. Expectant and the medical are safe for an ectopic pregnancy. You diagnose the ectopic pregnancy. Still, you can use expectant management or medical management, provided that the patient is clinically stable, no symptoms or very minimal symptoms, asymptomatic. The beta HCG is less than 3,000 in international units per liter. The ectopic pregnancy is less than 3 centimeters with no fetal heart on transvaginal sonography. You see it outside, less than 3 centimeters, no fetal heart. No hemoperitoneum, that means not rupture, no bleeding. Patient lives close to hospital, that's in case of an emergency where she had hemoperitoneum, rupturing of an ectopic, she would be able to reach the hospital quickly. As she is a non-ectopic, then they will go to the next step of the surgery. Patient can keep the follow-up appointments because in medical and expectant, we give them follow-up appointments. You do certain things and then you do a follow-up. You don't need to keep her in hospital. And no language barrier. In our situation, this is not a prerequisite. In other places, it is, whereby it is the multi-national, multi-ethnic, multilingual, different languages. So the people dealing with the ambulance or the management should be able to communicate with the patient, or the other way around. The patient should be able to communicate with those. So there shouldn't be a language barrier. That's in certain places whereby people don't speak same language. So having had those present, we go for the expected management. What is weight, then monitor the beta HCG every 48 hours until repeated fall in level, and then weekly until it is less than 15. So weight, monitor beta HCG. When it comes to normal, that's to say the ectopic has been resolved. Medical treatment. We used to give in the past injection of, or at least what could be used, is the injection of prostaglandins, potassium chloride, hyperosmolar glucose, but the one used now is the methotrexate, is a drug of choice. Give a single dose, measure the beta HCG, give another dose if the beta HCG did not fall. Just to explain this point, measure the beta HCG after giving the dose, then repeat it at 4 days after the dose and 7 days. Within this period between 4 and 7, there should be a fall at least of 15 or more, 15%. If less than 15%, you need to give another dose of methotrexate, the fall between day 4 and day 7. Warn about the adverse effect of methotrexate. After the treatment, the successful medical treatment, the ectopic will be resolved. It won't be there. Then you have to give proper, adequate, reliable contraception for at least 3 months, because methotrexate is teratogenic, and you warn them about the side effects of methotrexate, which are conjunctivitis, stomatitis, gastrointestinal upset. And the last or the third form of treatment is surgical. This is the ectopic treatment, sorry, this is the ectopic pregnancy here, and you do surgery for that. This is the uterus, the other ovary, the other tube are normal, no problem with them. This is the ectopic here, still intact, it did not rupture. You do surgery. This picture is through the laparoscope. So you do surgical treatment, either laparoscopy or laparotomy. Laparoscopy is the one we go for now. Shorter operation, shorter stay in hospital, less blood loss, less analgesia. And you take the ectopic pregnancy here. Laparotomy, if the patient is hemodynamically unstable. She had ruptured ectopic, unstable. Then low blood pressure, tachycardia, all signs of instability of the hemodynamic circulation. Then for that, you go for laparotomy. In both procedures, we do either salpingectomy, removal of the tube, or salpingotomy, opening the tube here, take the ectopic out, and repair it. This is salpingotomy. The one we do better, or we advise better now, is salpingectomy. So you take the whole pregnancy with the ectopic in it, sorry, the whole tube with the ectopic in it, salpingectomy, provided that the other side is normal. Other side, tube and ovary are normal. So in that situation, you do salpingectomy for the ectopic pregnancy. So we move to the last part of our talk, gestational ectoplastic disease. And we talk about the ectopic, possible etiological factor, presentation, diagnosis, management. We go to the gestational trophoblastic disease as the third cause of the bleeding early in pregnancy. Incidence varies according to ethnicity. In the Western world, or the Caucasian, in Europe and North America, it's less frequent. 1 in every 1,000 to 2,000, the incidence. While in Southeast Asia, it is 1 in every 200 to 300. So you tend to get it more frequently in Southeast Asia. Pathologically, it is the neoplasm of the trophoblast, which involves both epithelial layers, cytotrophoblast, syncytial trophoblast in different proportion in different cases. It contains all different proportions, and we will see what does that mean and what it entails. Pathogenesis of it: fertilization of an empty ovum. And that leads to one of two situations. Either a complete hydatid deformed mole, and here all the genetic material is paternal, 46XX, that is a duplication, as we will see in a minute, or partial hydatid deformed mole, where there is some maternal and paternal part of it. And the third one is the choriocarcinoma. So we go here, this is a complete mole, okay? Complete molar pregnancy. And here, this is an empty ovum being fertilized. There is duplication, paternal chromosomal duplication. It gets the two X's here, making 46X, and both X's are coming from the father. It's the maternal chromosome C is inactivated in the ovum. So let's say it again: maternal chromosomes inactivated, empty ovum, fertilized by sperm fehu, genetic material being duplicated to form 46XX, and that lead to the complete hydatid deformed mole. The other one, whereby two sperms fertilize an ovum, dispermy, and here it gives you, instead of 46, it will be 69. Either 69 3 X's, 69 2 X's and Y, 69 X and 2 Y's, and this gives you to incomplete or partial hydatid deformed mole. Partial means there is a molar tissue as well as there is fetal pus being there. So molar pregnancy could be complete mole or partial mole. This is the pathogenesis, how it occurs. So we go to the complete one. This is how it looks. generalized swelling of the villous tissue. This is how it looks here. All genetic material is paternal from the father. Diploid sperm duplicates its own chromosomes. We've got 46XX. Diffuse trophoblastic hyperplasia here, and no embryonic or fetal tissue would be seen. This is the when you get it out and you open the uterus and you see, and this is how it looks on ultrasound. We say snow form appearance. So this is the complete one. The incomplete or the partial one, focal swelling of the villous tissue. This is the focal swelling occurring here. Focal trophoblastic hyperplasia. There is embryonic or fetal tissue. Could be an embryo, it could be fetal tissue here, just the placenta. And triploid genetic material, as I have mentioned, 69 triple X, 69 two X's and Y, 69 X and two Y's. Usually one maternal and two paternal haploid sets. This is how it looks when you look at grossly, and this is on ultrasound how it looks, the two of them. Choriocarcinoma, the third one, highly malignant condition. It can follow a hydatidiform mole, whether partial or complete. Yet it occurs after miscarriage and sometimes after normal pregnancy and delivery. And this is a point where when we come and discuss postpartum hemorrhage, especially secondary postpartum hemorrhage, we should be aware that a rare situation, the choriocarcinoma could occur after a normal pregnancy and normal delivery. Metastasis goes to the lung, the liver, and the brain. The primary symptoms of it are gynecological, and it's usually vaginal bleeding, it can present with dyspnea, neurological symptoms, and abdominal pain. Who made the classification? WHO classifies trophoblastic diseases into two categories, pre-malignant and malignant. Pre-malignant, complete hydatidiform mole, the one we have described, or partial hydatidiform mole, the one we have just described. These are the pre-malignant. The malignant one is the choriocarcinoma, or invasive mole, or placental site tumors. So when we talk about trophoblastic disease, we have to think of pre-malignant conditions and malignant conditions. Risk factors for trophoblastic disease. Maternal age, the two extremes of the reproductive life, 40 and above, 15 and younger. Those two extremes of ages are very likely or likely to have risk for trophoblastic disease. Age over 40 or less than 15. If she had a previous hydatidiform mole or trophoblastic disease, she is likely to get another one again. Blood group AB has greater risk for choriocarcinoma than group O. Ethnicity is important, 10 times greater risk in East Asia, particularly in Korea and Japan. So ethnicity, more common Southeast Asia, less common in the European and North American world, and probably Africa. Symptoms and signs of trophoblastic diseases, whether it is a complete mole or partial mole. Usually irregular, recurrent first trimester bleeding occurring in almost 90% of them, and brown discharge. So recurrent bleeding early on. Usually the uterus is larger than the dates. And you'll find that the symptoms of pregnancy are exaggerated. And by those symptoms of pregnancy, exaggeration occurs in morning sickness could go to the state of hyperemesis gravidarum, or they could have hyperthyroidism, or they could have early preeclampsia. So these are exaggerated pregnancy symptoms. Some of them, obviously, are due to the hormonal effect of the disease. And the uterus is usually doughy in consistency and does not contract. Doughy like ajin, what do you call it? So symptoms: irregular recurrent first trimester, uterus larger than the dates, symptoms of pregnancy are exaggerated, and the feeling of the uterus. These are the symptoms. Signs you find: fetal movement are not felt. The uterus may feel almost above 20 weeks, but still no fetal movement. No fetal parts are felt, and no fetal heart is heard. As we have said, uterus larger than the dates, and we normally expect by the gestational age of 18 to 20 weeks to feel the fetal movement and to see the fetal heart early on, from 6 weeks onwards. So fetal movement are not felt at all, no fetal parts and no fetal heart. Pain from large fecal lutein cyst due to hyperstimulation with beta HCG high levels. Beta HCG stimulates the fecal lutein cyst, and it could form large cysts leading to pain. Vaginal passages of vesicles, sometimes with the bleeding, she could pass vesicles, looks like grape when they come out. High serum beta HCG with complete hydatidiform mole, but maybe within normal range in partial hydatidiform mole. So beta HCG is high in complete hydatidiform mole. Bilateral ovarian enlargement, palpably in almost 20 to 50%. And as we have said, these ovarian cysts due to hyperstimulation with the beta HCG. So we gave the clinical picture as well as the investigations needed. Now we need to do the investigations, or to complete these investigations. Ultrasound is diagnostic method of choice because it is safe, reliable, and a sensitive test. And it tells you how it feels. It is a snowstorm appearance, the one I showed you early on in a complete mole, whereby you see snowstorm appearance on ultrasound, and that's due to diffuse hydropic swellings of the chorionic villi. This picture could sometimes be mixed up with a picture of the degenerating fibroid or adenomatous polyp. So you have to be careful to use, beside that, the other investigations needed. Ultrasound. On ultrasound, no gestational sac or fetus can be seen. That's in the full mole. In partial mole, you'll see the focal cystic spaces are seen in the placental tissue, and the transverse diameter of the gestational sac is increased. So no gestational sac in a complete mole. You may see some gestational sac or some fetal tissues beside the cystic spaces in the case of partial mole. And I showed you the picture earlier on. Treatment, suction curettage, the standard treatment at whatever stage, however big the size of the uterus. Suction curettage, take the curettage or the products, take them for histological pathology, for histological examination, sorry. Sometimes you may need to do hysterectomy if the lady is over 40 years with a complete family. So you need to do hysterectomy in such a situation. The important point here when we come to the follow-up should be done even after a hysterectomy. And we'll see the follow-up and what to do for it. Treatment with the suction curettage, then she must use contraception after that. What is the suitable contraception? Barrier methods until the beta HCG comes to normal. After the suction curettage, we do follow up by beta HCG, during which period she should use a barrier method till the beta HCG comes to normal. After the beta HCG has returned to normal, it is safe to use the combined oral contraceptive pill, and in ladies over 40 nearing or reaching the menopause, she could have hormonal replacement therapy. Safe to be used. This is the contraception. Follow-up is important after suction evacuation or after hysterectomy in both situations. Follow-up is by serum beta HCG to be done every 2 weeks until it is normal. That is the serum. If one is doing in the urine, it should be done every month for 1 year post-evacuation, and then 3 months in the second year. What we use now is the serum beta HCG, not the urine. And the serum beta HCG initially checked every fortnight after the evacuation or the suction curettage. If it normalizes within 8 weeks, then the follow-up could go for 6 months. Yani you are doing it every 2 weeks. Within 2 months, you find it becomes normal. Then the follow-up should be for 6 months. If it did not come to normal level, even after 8 weeks after evacuation, then follow-up should go for 2 years. I'll say that again. Serum beta HCG, do it fortnightly till it becomes normal. Follow-up, generally, beta HCG becomes normal within 8 weeks. The follow-up should go for 6 months. The beta HCG did not come to normal within 8 weeks. The follow-up should go for up to 2 years. There are certain situations whereby we need to give chemotherapy. It is a benign condition, but we need to give chemotherapy. If the beta HCG is high 6 months after evacuation, we did suction curettage. During the follow-up you have just mentioned, 6 months later, still the beta HCG is high. She is a candidate for chemotherapy. If the beta HCG plateau in 3 successive samples, you did 3 samples, and the 3 are more or less the same. It's not coming down. This is what we mean by being plateau. If it's more than 20 international units, more than 4 weeks after evacuation, in which situation you need to give chemotherapy. If the beta HCG is rising in 2 consecutive samples, you did one and the next one is rising. So it means there is some trophoblastic tissue somewhere in the human body. If there is pulmonary, vulval, or vaginal metastasis, pulmonary, or the vulva, or the vagina, and you can see it usually as a small mass in the vagina or in the vulva. Heavy bleeding or gastrointestinal or intraperitoneal bleeding. Histological evidence of choriocarcinoma, as we have said, do suction evacuation, and then you send the material for histopathology. If the result comes as choriocarcinoma, then you treat as a cancer and you continue with the chemotherapy. If brain metastasis, liver metastasis, GIT metastasis, lung metastasis shown by X-ray. So if there is any metastasis of the condition, then that is where you need to give chemotherapy. Thank you very much. And we stop here at the end of the second part of the bleeding in early pregnancy.